Welcome to Intensive Outpatient Services, Clinical and Administrative Issues, Tips 46 and 47, brought to you by allceus.com. Intensive Outpatient Treatment, or IOT, a lot of us call it IOP, Intensive Outpatient Programming, whatever, it's the same thing. It needs to be multidimensional and biopsychosocial. What does that mean? It means we can't just attend to the addiction. Because if somebody is in that place where they need the level of care provided by intensive outpatient, that tells me that their environmental domain, their social supports, their behavioral domain, lots of the domains that assess on the ASAM are probably out of whack. So they're going to need multidimensional services. IOT recognizes that dual disorders are chronic. That means they're there, and they come and they go, and they come and they go. And you can have flare-ups, if you will. For example, major depressive disorder can be recurrent. Bipolar goes in cycles. We need to recognize that there are certain things in mental health that tend to be cyclical, and that can serve as a trigger for substance abuse. Intensive outpatient therapy values case management. In order for somebody to successfully find recovery or get sobriety or whatever you want to say, they need to attend to that hierarchy that I talk about in every PowerPoint. Case managers can help them get safe housing, make sure they're getting food, make sure they're attending to their activities of daily living and taking their medication as prescribed if they have any medications. Case managers are very helpful with helping them establish linkages, not only to meet their basic needs, but also with 12-step programs and other social support programs. IOT blends evidence-based with community-based services. That means it takes our services, which theoretically are evidence-based, and combines them with things like maybe food stamps or support from a church or some other types of supports, transportation, in order to help the person meet all of their needs that they need to do in order to stay clean and sober. Core features of intensive outpatient therapy: 6 to 30 contact hours per week. Now, that's a lot. And generally the 6 is something that people do as they're stepping down, right before they step down to traditional outpatient. So 6 to 30 contact hours per week. It needs to be individualized with step up and step down levels. Step up, if they're stepping up from traditional outpatient, or maybe they're only coming 15 hours a week but they've relapsed. So maybe they need to step up to 25 hours a week, or 15 hours a week plus 1 meeting a day. Step down levels are just like they say, it's less intensive services. They're spending less time with us and more time in the community, enhancing their recovery and developing sober social supports and connections. It's a minimum of 90 days for IOP, followed by a step down into traditional outpatient. Some people call it relapse prevention. Some people call it aftercare. Whatever your agency calls it, you don't just take somebody who's been seeing you 6 hours a week and say, oh, okay, you seem to be doing fine. Toodles, good luck. You want to step them down gradually. Enhanced services include ambulatory detoxification, if that's possible. Some agencies have it, some agencies don't. Ambulatory detoxification means we know the person used. We're not going to commit them to a residential facility. They're going to come in every day and see a psychiatrist or a medical doctor who can monitor their vital signs, provide them any medications that they need, and they have somewhere safe that they can go home and stay in order to detoxify, such as a home, or maybe even their parents' house or their sister's house where they can sleep on the couch. Somewhere where there's someone sober who can make sure that they don't go into some sort of a medical crisis. Most of the drugs people take don't have significantly dangerous detoxification. Now, the depression that comes afterwards can lead someone into a depressive episode and they may become suicidal. That's dangerous. But detoxing off of a lot of the medications and a lot of the drugs that are out there in and of itself is not medically dangerous. Alcohol is one of the major exceptions. So is your anti-anxiety medications. A lot of that is because of the mood with the anti-anxiety medications. But alcohol, blood pressure can actually go up and people can stroke out. So it's important to remember that if somebody's been using heavily, don't just assume that they can go home and sleep it off. That's probably not going to work. Not to mention the fact that if going home was a safe place where they could sleep it off, they wouldn't have relapsed in the first place. So we need to make sure that they've got a safe place that they can go to take the medication, do whatever they need to do to detoxify. We need to make sure that a physician or a program manager for a detoxification unit is seeing them and knows what they're doing and is monitoring them. Child care. If your clients don't have anything to do with their kids, then they're not going to be able to attend treatment. This is especially important or present when the public schools are out. A lot of our clients have children that are in public schools. So during spring break, Christmas break, summer break, teacher work days, all those different breaks, our clients don't have anything to do with their kids. A teacher work day, maybe they're just absent from the program for that day. But if you're talking spring break, that's an entire week. Christmas break is 2 to 3 weeks. We don't want our clients to be out of treatment for that long. If they could go an entire week and stay clean and sober, they probably wouldn't need this level of care. IOP also provides outreach. We go out and we reach out to those people who are important to our clients and we say, hey, come in and learn about addiction and learn how you can help your friend or your spouse or your son. We provide education and let people know that these services are out there. You don't have to necessarily go to residential. There is an alternative. And as I said earlier, it provides case management to make sure that people are getting their basic needs met. Core services, screening. Is this person even remotely appropriate for IOP? If you screen them and you say, yeah, IOP might be useful, then you do a full biopsychosocial assessment. If you go through that and it appears that they would not only be appropriate for IOP as far as the intensity of care, but they can handle being in a group situation, then great. You start getting them prepared to go to IOP if that's what they choose, and develop a treatment plan. The first phase of IOP is basically treatment engagement. We need to get them to buy into the program, to feel comfortable with their peers, and to become invested in what's going on, not just show up 4 days a week because the court says they have to. Group, individual, and family counseling. You can't take Jim Bob out of a dysfunctional environment, bring him into treatment, and expect him to be able to go back into that dysfunctional environment and stay clean and sober. That's not realistic. So we need to help Jim Bob modify his environment. Family counseling, that's helpful if the family's willing to do it. Help provide education about addiction. There's probably a lot of trust issues, there's probably a lot of anger, there's probably a lot of stuff that needs to be gone through. And until that stuff is weeded out, it's going to be difficult for the family to reassimilate and find equilibrium once Jim Bob gets clean and sober. They're going to be expecting him to relapse and maybe setting up a self-fulfilling prophecy. So we need to make sure that we help them deal with their resentments, their anger, and their concerns. Group counseling. One of my first mentors said he would never do individual with an addict. And of course I looked at him like he had 3 heads because he was a brilliant clinician. And of course, so I said, why? And he said, because I'm outnumbered. You have the addict and the sober person, and it's just me. It made sense. You have a person who wants to do the right thing, but you have that addicted voice coming out. So it's important to make sure that you address both of those things. And the best way to do that is through group, because a con can't con a con. If that makes sense. Yeah. People in group not only can call other group members out, but they can provide a sense of normalization, they can provide social support, they can provide a lot of information that maybe you can't, or even if you could, it's maybe accepted a little bit better from peers. We can educate throughout the day. But when it comes from somebody who's been there, when they can say, yeah, I experienced the pink cloud, this is how I handled it, or this is how I experienced it. It's important. Psychoeducational programming. We talk about treatment planning beginning with knowledge, skills, and abilities. Well, psychoeducational provides that knowledge. What is depression? What causes depression? How does abusing cocaine mess up the neurotransmitters and lead to a feeling of depression? How can we make this better? What can we do in our daily lives so we sort of stack the deck to help prevent depression? What is cognitive behavioral therapy? These are all things that we can talk about in psychoeducational programming. And integration into support groups. Our goal is to teach them how to fish, not give them a fish. We don't want people coming to IOP forever. And trust me, they don't want to come to IOP forever. I think I've only met like 2 people who've really enjoyed coming and wanted to continue to come forever and ever because it was safe. And that, in my opinion, is establishing a dependency. They need to create a safety net out there. Start slowly. Have them start going to 12-step meetings. Have them get a sponsor. Have them find a home group of, a few select people that have significant sobriety. Help them start integrating into other pro-social, sober environments. Volunteer work, their church, maybe a neighborhood cleanup, whatever it is that does it for that person. Community education classes. Boredom is not something we really want to occur in early recovery, so we need to help people learn how to build an environment that supports their recovery. Relapse prevention training. We need to help people identify what their triggers are. If they were able to stay clean and sober, they wouldn't be here. We need to educate them and help them realize that a relapse begins long before they pick up again. A relapse begins in their thinking. They go back to that stinking thinking. We need to practice refusal skills. We need to remind them to stay grounded. We need to help them figure out what it is for them, that one particular person that's going to help them stay clean and sober. It's not the same for everybody. We need to regularly screen for substance use. Just because they're not using their drug of choice does not mean that all is clear. If you're in recovery, you're not using substances. Just because alcohol is your substance of choice and you test positive for marijuana, that doesn't mean you're clean. That means you didn't happen to use alcohol, you just chose something else. That's substituting an addiction. Doesn't work for me. Vocational and educational services. Like I said, we don't want people to be bored. We want them to not have the stress of financial problems. We want them to feel like they're succeeding at achieving their goals. And a lot of times that means helping them enhance their vocational profile. Hook them up with community resource centers that are designed for just that. You don't have to do a voc assessment. That's what voc rehab is for. That's what a lot of our one-stops, or whatever you call it in your state. Some people need additional education. Well, let's look for grants. Let's help people figure out how they can get that education. And then we refer to wraparound services. Do they need financial counseling? Do they need, again, vocational counseling? Childcare, legal assistance, you name it. What do they need? What are their stressors that are out here? I'm not making enough money. I've got pending felony charges. I have 6 kids that I need to take care of every evening. I don't have a house that's in a safe environment. All of these stressors, we need to say, okay, let's list them and start knocking them off one by one. I may not be able to help you with all of them, but I can refer you to the person who can. And provide mentoring. People in your group who have been in your group longer are mentoring relapse prevention strategies. You can mentor how to live a sober, happy life. They learn a whole lot more from you what you do than what you say. I remember there was one treatment center that I went to, and all the counselors seemed miserable all the time. And the clients basically didn't want to recover because they're like, if that's all there is to recovery, I don't want it. Let's talk about the principles of intensive outpatient treatment. You're going to have a wide spectrum of clients. You're going to have people who are addicted to different drugs, who've been addicted for a year and who've been addicted for 20 years, who are functioning plus or minus 10 points on an IQ scale. You're going to have to attend to a wide array of people. You're going to have newbies coming in who are just really starting to get out of that fog that was caused when they used drugs. And you're going to have people who've been in the program for a while who have all the drugs detoxed out of their system and they're thinking more clearly. You need to be able to present classes that are meaningful to all these people. One of the things that you can do is make sure to provide handouts. Those who are still in a fog may not get it right at that moment, but if you write it down and they can review it later, then it may be more meaningful. You're also attending to different learning styles. So make sure to provide activities because people remember what they do more than what's just yapped at them. Have them apply it. It doesn't necessarily mean they have to talk, but say something like, think about the last time you did something. They will think and you'll see people's heads nodding. And if people aren't engaged in the class, they'll be doodling and just kind of off in Never Never Land. You know you need to try to engage that person somehow. Make sure that treatment access is straightforward and welcoming. There's no wrong door. That means if they come in initially as a traditional outpatient client or as a residential client or they've never been seen before and they just present for an assessment, maybe they go to the detox or maybe they go to the crisis stabilization unit or the emergency room. Make sure that no matter where the person enters the system, they can get into your program if that's what they need. Enhance existing motivation. Remind them to continually do decisional balance exercises and highlight the reasons for change and the reasons for not staying the same. Help them identify goals and supports and not focus on 6 months from now, but what did you do today? You stayed clean today. That sounds like a pretty good thing. You need to establish trust between yourself and the client. You're representing the system. A lot of our clients have not had good luck being involved in the system, whether it's been foster care, Department of Children and Families, the legal system. They felt like their needs haven't been heard. So it's up to us to establish that trust by not making promises we can't keep, by hearing them, by individualizing treatment, and by respecting their preferences. We want to retain clients, and it's important to provide individualized assessment and treatment. It's going to be important for those people who are chronic relapsers. for those people who need periodic episodes or tune-ups of care. We need to be able to monitor abstinence and help clients integrate into support groups. We need to be able to ensure they can link with providers, if it's us or their primary care physician, who can prescribe medications to help them manage their co-occurring disorders. Providing education to clients and family members. Groups, great place to do it. But you know what? Families don't show up to groups. They don't want to hear it. They have the identified patient. They're not ready to address any of their stuff. Groups are sort of overwhelming to them. They've got too much on their plate. They're already taking care of kids, whatever. There's 1,000,001 excuses. So make it easy. Online videos, handouts, brief sessions when the family comes to visit, like 15, 20 minutes with the counselor. Little things to help the family start to progress, so when Jim Bob has advanced all the way out here and he gets discharged from treatment, the family's at least here. They may not be progressing at the same rate, but at least they're a lot closer, and Jim Bob is not going back into the exact same environment from whence he came. It's also important to educate employers. What is Jim Bob going to need? Is he going to remain clean and sober? Now, obviously, without a release of information, we can't go and call up Jim Bob's employer and say, hey, I'm discharging him from treatment. Just wanted you to know to be on the lookout. No. But it is important to provide community education so employers know what to look for in someone who might be abusing substances and ways they can support people who are in recovery. Recovery does not equal relapse. People can be in recovery for 20, 30, 50 years. They don't have to relapse, but it's important for employers to be aware of things they can do to make it more conducive for someone to stay clean and sober. We need to use evidence-based practices, not just go in there and wing it and whatever we say, and it's, a group. There was one clinician I knew, unfortunately, who thought that playing episodes of HBO's Intervention and then having discussion about it was an appropriate group session. Not so much. Most of the clients who came out of that group said I was more triggered when I left than I was when I came in. I said, I'm not surprised. That's not evidence-based. So let's provide evidence-based training and materials. If you don't know what that is, there's a national registry of evidence-based and promising practices. Google it. Improve program administration. That means making sure you have that no wrong door thing going on. Make sure it's accessible. Make sure you are minimizing any of the things that might, make a client not want to stick around. Too much paperwork, too many demands. Maybe it's not at the right time or it's not convenient. Maybe you're in a rural area and people have to drive 50 miles to get to the center. Well, it's going to be really hard for them to get there 5 days a week, especially if they're poor and rural, and gas right now is $4 a gallon. So it will be important to figure out how you could administer this program in a way that is meaningful and accessible to all of your stakeholders. Doing a biopsychosocial assessment. Bio is your housing, food, and health issues. Psycho, your past, present, mental health and trauma issues in yourself or in the client's person and in their family. Why the family? Because we know a lot of mental health issues can be or do have something of a genetic link. And even if it's not genetic, if they grew up in a family where mom was depressed all the time, they probably learned some coping skills or some ways of perceiving the world that are more depressive in nature. So it's important to know what type of environment the person came from and what kind of mental health issues are common in their family. Because what we grow out of is generally what we take with us. Past and present substance abuse issues in the client and in their family. What did they learn by watching Uncle Bob when he would come over on Sundays? Or Dad when he would come home from work in the evenings? Past treatment successes and failures. Let's not reinvent the wheel. If they've already been in treatment, what works? Let's start there. I don't want to start just kind of throwing stuff at somebody to see what's going to click. If you know what works, tell me. Identify whether they're suicidal or homicidal or have ever been, and any history of family violence. Figure out where their self-esteem is. Generally, if they're coming into IOP, self-esteem's in the toilet. But what do they feel good about? What are the things that they still feel proud about or want to feel proud about again? And what are their coping skills, their strengths, and their resources? Everybody has them. Everybody has them. Are they friendly? Are they flexible? Are they smart? Are they analytical? How do they cope? In the past, when things have gotten stressful, what do? Do they go on a run? Do they talk to a friend? Besides using, what do? It may not work completely, but if it works a little bit, then we can tweak it. What's their relationship like with their peers? And do they have any clean, sober peers? How's work going? If work is one of their major sources of stress, then we're going to need to address that. If work is one of their major sources of self-esteem, then great, let's embrace that. In our society, people work. If they can't work, if they've become disabled, and unfortunately the way things are written, the way laws are written, if you're on disability, you can only work so many hours before you start losing money, and then it's actually more financially beneficial to stay on disability. So anyhow, that aside, people need something to do that gives their day some meaning, that gives them interaction with people, even if it's volunteer work. What is it that they would like to do? If they hate their job or they're unemployed, what do they want to do? Can we make that happen, or can we help them start going in that direction? Do they need a referral to a vocational rehabilitation counselor? Legal issues. Are they involved in the legal system? Are they on probation? Do they have charges pending? Do they maybe have warrants and they're not quite sure? That's a big one. A lot of stress rests on people's shoulders if they're in treatment and they're not sure if they've got warrants. Then every time law enforcement shows up, they scatter. And the take-home message is, if you get everything, all your ducks in a row, and you know you're doing the next right thing, then you won't have to be afraid every time you see a cop car or a policeman or hear a knock at the door. And financially, treatment costs something depending on their insurance and your programming, but they need to have the money to keep a roof over their head, food in their tummies, and their medication. Sometimes they need help prioritizing this. There was one patient that I worked with who would get her food stamps at the beginning of the month, and that first week she would literally eat surf and turf, and she'd have no money left over to pay for her medications. So instead of being a little bit more moderate in what she ate, or only having surf and turf once, she would have it for the entire week and then not be able to get her antipsychotics. So we had to work with her to help prioritize that, and that had to become an objective on her treatment plan. Clinical considerations. Not everybody belongs in group. People with access to stuff probably don't belong in group, at least not a group that's designed for substance abuse. Adolescents and people who have cognitive challenges that make them have difficulty with abstract or future thinking. Fetal alcohol spectrum disorders are Classic. You can have somebody who's 40 years old who can't really predict the future. If they do something, the consequences are a mystery to them, even if they've done it 6 times before. Impulsive, short attention span, vulnerable to peer influences. Again, people with FASD are followers. They are very, very easily manipulated. Frequent emotional fluctuations as those hormones go up and down in adolescence. Or someone who has a mental health issue that is not quite stabilized yet may not be appropriate for a group at this time. Lack of involvement in pro-social activities. If the only time that they are safe from relapse is when they're in your 4 walls, then chances are they're going to be chronic relapsers, and having someone come to treatment while they're under the influence triggers everybody else. So we need to make sure that the people we're working with have pro-social activities and supports on the outside, so the chances of them coming to group high are slim. Or if they have pessimistic or fatalistic attitudes, if they are going to naysay everything and just heckle you throughout group, not helpful. So, once you've determined whether somebody can even survive in group, you use the ASAM to determine what level of care they need. Do they need once a week group, 6 hours a week, 30 hours a week? The ASAM assesses multiple dimensions, including their environment, their ability to cognitively understand what's going on, their current behaviors, their medical stability. Level 2 is your intensive outpatient. These are people who were pretty darn sure can't stay clean and sober, only coming in once a week, whether it's group or individual. Sometimes people end up in intensive outpatient even though they really belong in residential, because it's not the best fit for that person at that time to go into residential. Treatment has to be individualized. ASAM provides a guideline, but you need to be able to make a clinical decision and support that decision with a clinical rationale. Or Jim Bob said he wasn't going into residential, so the only thing he would accept was IOP, which, where I came from, we said that was giving them just enough rope. If they are able to succeed in IOP, wonderful. I used to tell people, please prove me wrong. I really am concerned about your ability to maintain your sobriety in IOP, but if you believe you can, please prove me wrong, because I have no problem with that. Residential services obviously is a much higher level of care. And too often I see people go from residential to outpatient. They go from level 3 to level 1 and don't even touch level 2. Think about it. 24/7, everything's controlled. You're told when to shower, when to eat, when to go to group. You don't have to pay bills. There's no outside influence, no crazy person calling you, no dealers bothering you. And then all of a sudden, however many hours in a week but one, you're inundated with life. It usually doesn't turn out well. We want to help people segue out so they can learn to deal with life on life's terms gradually, instead of just kind of throwing them out and going, well, we'll see if you can swim this time. Not the best idea. Key aspects of intensive outpatient. Treatment frequency and intensity is individualized. Ideally, anyone who starts with at least 9 hours per week for 90 days. It can go down to 6 hours a week right before you step them down to regular outpatient. But at least 9 hours per week for 3 months. During this period, you're going to engage them in treatment and help them work through early recovery. Most of this is the knowledge stage. They're learning about their addiction. They're learning about themselves. They're learning about their triggers. And they're starting to learn and practice, dabble with new coping skills. Engagement. We want to initiate a treatment contract, a treatment plan. Have to do that anyway. Resolve acute crises. If they think they're going to jail next week, we need to resolve that. If they are in crisis because their significant other just left them, we need to help them find some stability with that so they can focus on recovery. If they don't have anything to do with their kids, we need to help them figure out how they're going to do that or how they're going to get to and from treatment. These are all more or less acute crises. Treatment retention is going to be vastly improved if you make sure you help them identify any little bumps in the road and make a plan. If they start yes-butting you or making excuses or constantly coming up with new crises, that tells me they might be more in pre-contemplation. And so we may need to look at educating them about their use pattern in comparison with others and using that frames approach that was talked about in tip 35. We need to engage in a therapeutic alliance. I'm not here to force you to do anything that you don't want to do. I can force you to go to meetings. I can force you to sit here and pay attention in group, sort of. But if you don't want to, you're not going to retain any of it. And at least in all the settings I've ever worked, you can't force anybody to do anything they don't want to do. I mean, within reason. If you're working in a crisis stabilization unit, obviously there are exceptions. But there's no way I can force you to pay attention. I can force you to act like you're paying attention or kick you out of group. But we need to develop that therapeutic alliance so the client has buy-in. They need to think that, hey, I might be able to get something out of this. You start that by involving them in the preparation of their treatment plan. What are we going to go over for the next 90 days? This phase lasts a few days to a few weeks, depending on any trust issues your client may have and how fast your program goes. Treatment engagement phase. We want to confirm their diagnosis, their eligibility, and their appropriate placement. If they're in your group for a week and you're going, I don't think Jim Bob's getting anything out of this, or it's clear that cognitively they can't keep up, you may need to make a referral. Ideally, the assessment would have already been completed. The treatment plan is completed in the first week. We've provided them feedback from their assessment to help them understand where the weaknesses in their relapse prevention plan might exist. We explain program rules and expectations, address the acute crises, resolve any administrative issues. That can be, what do I do with my kids? I can't get here by 3 o'clock. I can get here by 3:30. Is that okay? Transportation home if the buses aren't running. Whatever the issues are that are going to get Jim Bob there and keep his butt in your seat until the end of group and then get him home safely. And foster therapeutic alliances between yourself and the client and group members. If you have 15 people sitting in there, but they would rather not talk to each other ever, it's not going to have the same benefit as a cohesive group. Begin psychoeducational activities. Start at the beginning. This is addiction. This is why we develop addiction, or what the theory is, that we've overwhelmed our coping skills and we didn't have the tools to deal with life on life's terms, for one reason or another. So let's look at all the reasons this might have happened for you and figure out what your triggers are for use. And then we can figure out other ways to cope that don't involve using. Identify sources of social support and initiate family contacts and education. In order to complete phase 1, the assessment and treatment plan need to be completed. If you worked for me, that was the first week. The client needs to be completely detoxed And that includes if he or she has relapsed during phase 1, they need to be completely detoxed. Remember, some drugs, like your anti-anxiety medications, have what they call protracted withdrawal. So 30, 45 days after ceasing use, they may have sort of a second detox. It's imperative that people have gotten through any protracted withdrawals, and they are, for all intents and purposes, clean. And they need to be attending and participating. Attending and going to sleep doesn't count. Attending 70% of the time doesn't count. We usually set an attendance level of 95% of the time, unless the person has a doctor's note. If they're not regularly attending, they're not getting the benefits of IOP. The next phase is early recovery. We want them to be abstinent, to sustain their behavioral changes that have helped them stay abstinent, like not taking that route to work that goes past their dealer's house, saying the Serenity Prayer, going to meetings, whatever it takes to help them deal with their triggers. Do a more thorough identification of relapse triggers and develop relapse prevention strategies. Identify and begin to resolve personal problems, and begin active involvement in 12-step or other mutual help programs. This is 6 weeks to about 3 months. They need to be able to have a beginning knowledge of how to live a clean and sober lifestyle. Clean means you're not using. Sober means you've changed the stinking thinking and you've got hope. You're being honest with yourself and others. You've got faith that the program works, that you can do this, that you can stay clean. You've got faith in your higher power. You've got faith in other human beings. You've got the courage to face crap that's not all that pleasant. You've got the discipline to do what you need to do, even when you don't want to do it. Those are behaviors of sobriety. Help clients follow their plans to sustain abstinence. We help them look back over their relapse prevention plan and go, what did you do? What did you not do? What worked? What didn't? How can we tweak this to help you better? Assist and identify and develop strategies for relapse triggers. One of the relapse triggers may be Thanksgiving dinner with their family, or any dinner with their family. Yet they feel obligated to go, at least on the holidays, to participate in these celebrations. So how do they deal with it? What are their strategies? Making sure that their sponsor is going to be available, going to a meeting beforehand, going to a meeting afterwards, setting a time limit for how long they're going to be there so it doesn't turn into an all-day affair. There are a lot of different strategies people can use. You need to work with your client to identify some of these things and how they can work through them. Initiate random drug tests and provide rapid feedback. On-site tests are wonderful. If it comes up positive and the client says they haven't used, you can always send it to the lab. 99.98% of the time, the on-site is accurate. As long as you use, I should caution you, you have to use proper collection procedures. You have to see the collection. If you don't see the collection, you have to take all the steps of having people empty their pockets and put bluing in the toilet, turn off the water to the sink, have them wash their hands ahead of time, because a little bleach on the finger can go a long way towards distorting results. If you read your manuals or have your drug testing company come in, they can tell you all the precautions you need to take. Your state laws or your accrediting bodies also provide guidelines for what you need to do in order to respect the integrity of the client. You're generally not going to have a female counselor go in with a male client, and vice versa. Some of that is a little bit different if the clinician observing the specimen is a nurse. They have slightly different rules. But if you're a counselor, general rule, females can go in with females, males can go in with males. Even doing all those, there are ways that people can beat the drug test. So, I mean, if they're going to beat it, it's going to probably be beaten on-site and in the lab. Make sure your tests are accurate. Make sure your testing procedures are very, very tight. Assist people in developing and strengthening positive social support networks, not just through a meeting or the meeting. Multiple meetings, multiple people, multiple environments. It doesn't have to all be recovery oriented. Maybe they join a hiking club. Maybe they start volunteering with an animal rescue. Maybe they, I don't know, whatever it is that makes them happy, that's a positive social environment, is going to help them stay clean and sober. And continue appropriate pharmacotherapy, medical, and psychiatric treatments. If they have a co-occurring mental health problem that requires medication, make sure they're taking the medication. It's a no-brainer there. In order to complete, they need to be abstinent for 30 days or longer. They need to have completed their treatment plan goals, or at least 90% of them. They need to have created and implemented a relapse prevention and continuing care plan. I like this to have been implemented for at least 30 days before discharge. They need to have participated regularly in a support group, maintained a sober social support network, including frequent, if not daily, contact with their sponsor. And they need to have resolved any medical, psychiatric, housing, or personal situations that might trigger relapse. Okay, so they've done all this and they step down to outpatient treatment. We want to help them solidify their abstinence, use their relapse prevention skills. They're practicing what they learned now. Improve their emotional functioning so they don't go from 0 to crisis in 2.1 seconds. Broaden their sober social support networks and address any other problem areas that may be arising. Maybe they start having difficulty with somebody at work, and engaging in a dialogue or being in a situation that was not comfortable is a relapse trigger for them. So, okay, now we're putting this thing to the test. Let's help you learn how to address this sort of situation. This lasts 2 months to a year. In this phase, we help clients practice relapse prevention skills. We teach new coping skills, identify unmet biopsychosocial needs. If all of a sudden we realize that, oh, this person may have a mental health diagnosis, or their nutrition is awful, or it looks like they may have hypo or hyperthyroid or something else going on that requires a medical exam, we need to help make that referral and encourage them to take the next right step. Assist them in locating community resources for things to do, for services they need, and for social and possibly financial support if needed. Encourage support group participation. Emphasize the importance of spirituality and sober values. Again, honesty, hope, compassion, courage, discipline. All of those things, all of those principles that are part of a 12-step program. Even if they don't embrace the 12 steps, the principles that underlie the 12 steps are the same principles that underlie most religions and most non-religions. There's nothing that can hurt you about being disciplined and courageous and honest and compassionate. Provide feedback on random drug test results and continue treatment plan implementation. In order for them to graduate from outpatient, they need to have sustained abstinence, improved relationships so they have 3, 5, whatever arbitrary number you come up with, sober social supports. Ideally, they've improved relationships with those people who they call their family, whether they're blood relatives or not, those people who they spend holidays with, who they call when they're in trouble. Improving relationships is vital to sustained recovery. They've improved coping and problem-solving skills, obtained drug-free, stable housing, continued participation in a support group, and obtained assistance with other problems. Remember, we identified those problems and helped them link, but they need to go that extra step to actually contacting the agency and getting the help and following through with it. Making a doctor's appointment doesn't do a whole lot of good if you don't go to the doctor. Stage 4 is continuing care. This can be a 1-hour group once a week. The goal is to maintain abstinence and wellness. That means abstinence and also just focusing on stress management. Are you sleeping enough? What kinds of things make you happy? Develop independence from the treatment program so you're not reliant on your counselor anymore. You've learned to fish. Make social and support network connections and establish recreational activities. This goes on for years. Your recreational activities can be with your 12-step program, or it can be different. But you need to have things to do. Going to work, coming home, watching TV, going to sleep, getting up and going to work again is eventually going to wear on your nerves. In continuing care, we assist people in developing a plan for continuing recovery, acquaint them with local resources. How do you find out what's going on in the community? What can be done? Encourage attendance at alumni or booster sessions, and provide biannual checkups. Clients may need community support forever. There is nothing to say that there's a time where it's recommended you stop going to support group meetings. Support group meetings can't hurt you. You may need to be in touch with that community forever. And hopefully those people are integrated into your social support network so you don't want to miss meetings and you don't want to detach yourself from community support. Service linkages. We need to provide assessment or figure out somewhere where they can get it. Treatment planning. Group and individual counseling. Not everybody's going to want to hang out their dirty laundry in group. And they may have some stuff that they need to get off their chest. So individual counseling needs to be there. Individuals also give you a chance to review the treatment plan and modify it as needed to work best for that individual. Psychoeducation, very important. They need to learn new skills and they need to learn how to strengthen the skills they have. Pharmacotherapy, not always needed. A lot of the times it's helpful. Many clients report that in the first 2 years of recovery, they don't see much in the way of colors. It's just kind of gray. All their neurotransmitters are, wonky. So it's hard for them to get really excited about anything. It's just like, okay, yeah, whatever. I liken it to Eeyore from Winnie the Pooh. Enduring that for 2 years is extremely challenging, if not impossible, for a lot of people. So even if their depression or their anxiety is a result of the chemical imbalances created from their substance use, a short course of medication may be useful in helping them stay clean and sober and realize that life without drugs really is pretty fun. Drug testing and monitoring, we got to do it. It's the least favorite part, but we got to do it. Case management. If you can link them to a case manager, that's a whole lot more ideal than doing it yourself, because case management takes a lot of time, but it's imperative to make sure that we help people establish and follow through on linkages with resources in the community that they need. And community-based support groups. Know where the meetings are. Know where the meetings are that have childcare or that are child-friendly. Know where the meetings are that are on the bus routes. Know how to figure out this information if you just don't know it or have a list of it on your desk. 24-hour crisis coverage. Especially in early recovery, somebody may wake up from a nightmare or wake up from a dream about using and really be triggered and need to be talked down. If they have not yet contacted a sponsor, or if their sponsor's not available, we need to be there for them. We need to be there if something else happens and they actually are in some sort of a mental health crisis. It doesn't need to be you, Jane the therapist, but it needs to be a representative from your agency. They need to know that they can contact somebody at the clinic and get help sorting through whatever the crisis is. Medical and dental treatment, very important. Dental's one we don't think about a lot. But dental, not only does it cause pain, but a lot of people are very self-conscious about their teeth. And so that makes them feel less good about themselves, which hinders them getting a good job, which hinders them developing social interactions because they're embarrassed about their teeth. So it's important to help them get dental treatment so they can smile and they can feel comfortable interacting with other people. Dental treatment can also, or poor dental work, or lots of cavities, can also keep people from eating a balanced diet. And we know that nutrition is one of those building blocks that people need in order to experience full recovery. Vocational and employment services and the wraparound services that we've already talked about. Treatment entry and engagement. During the screening, ask the client what his or her perception of the problem is. Explore the client's expectations or hopes for treatment. Support their commitment to change. Offer hope. Assess their readiness for change. And complete some sort of a simple screening instrument. There's one in Tip 11. You may use the CAGE. You may use a variety of different assessment instruments. The SASE is another one that's often used. In the Biopsychosocial Assessment, you want to assess their mental health, past, present, consequences, interventions, what worked and what didn't. Same thing for substance abuse. We've already talked about this some. I'm just kind of reviewing it for you. And any family history of mental health and substance abuse. And then complete an integrated summary. Now this is one we haven't talked about yet. Integrated summary means you take all these pieces. What their environment was like when they were growing up, the coping skills they learned, their current stressors, what's going on, what kind of needs are not being met in their hierarchy. And integrate that into a picture so you can understand how Jim Bob got from point A to treatment. How did he get to this point in his life and how can we intervene? It's not a regurgitation of Jim Bob is a 38-year-old white male who was born in Gainesville, Florida and is presenting with cocaine dependence and blah, 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 blah. It's not just spitting back what you got. It's taking it and mushing it together to help yourself, other people on your team, and Jim Bob figure out how all this stuff interweaves in order to create Jim Bob the addict, and what strings we need to pull to unweave it so we can have Jim Bob the sober person. Integrated summaries are sort of stories and somewhat hypotheses, but should never be just straight regurgitations of the facts. Treatment planning. Involve the client. Make sure the goals are observable and measurable and sequential. knowledge, then skills, which is practicing things in group, then abilities, which is practicing things outside of group and coming back and saying how well it worked or it didn't. Link people with necessary resources. Family-based services. Engage the family. Look at reasons they may resist coming to treatment. Remember I said that there's 1,000,001 excuses? Well, here are some of them. Domestic violence. If Jim Bob is an angry drunk, then Jim Bob's spouse and family may not be interested in coming to treatment. There may be other issues such as shame, fear of revealing family secrets, or resentments. If you can, involve the family in the intake. Offer written invitations to participate. Provide family-only educational groups where Jim Bob's not there. Have an Al-Anon group going at your facility. Provide educational snippets, if you will, nothing more than 10 minutes, on your agency's website. Maybe it's password protected, so only families of clients can go watch these videos. But it might help them learn a little bit more in an environment that is conducive and safe for them. Family education is important. Multifamily groups are super helpful. Just like regular groups are helpful for people in recovery, multifamily groups provide families the opportunity to get together and go, this is my experience, and share. And other families can go, yeah, when Tom came out of treatment, I was concerned he was going to relapse too. This is how we handled our situation. They can support each other. Family therapy for individuals and couples, and maybe even child-focused. Family retreats. That's usually reaching. It's not usually possible to have a family retreat just because of administrative and financial constraints. But if you can, that's wonderful. And make sure that support groups are available. Clinical issues in the family include trust reestablishment, how they can have sober fun. People may not remember what it's like to have fun with mom anymore. What do we tell the Joneses? What do we tell the neighbors about where you've been for the past 90 days? And resentment of the consuming nature of recovery. First you were addicted to this drug and you were always gone and you were always doing this and you were hawking stuff, and now you're always at meetings and you don't have time for the family. It's important to help families understand how vital treatment and support group meetings are to helping their loved one solidify the skills necessary for recovery. Client retention. We keep clients in the program by providing individualized treatment. Understand their treatment history. What's worked? What hasn't? If you have a client that comes in and tells you what they're not going to do, don't turn around and tell them, okay, well, I want you to do it anyway. Understand whether they're involuntary or voluntary and how to deal with those. Use motivational techniques. Tip 35. Flexible scheduling. Some people can do morning, some people can do evening, some people can do midday. Is there a way you can accommodate all of those people or 2/3 of them? Use the group to engage the client. If it's just you and the client, you might as well be having an individual. The client needs to form alliances or bonds of some sort with the group members. That way they can support each other and pull each other up and give each other kudos when kudos is due. Network with those involved in the client's recovery. If you can get family buy-in, then they're going to support the client in coming to treatment. Deliver services throughout treatment. Don't have it be really heavy on the front end and then Jim Bob's just coming and sitting in a room for an hour every day at the back end. It needs to be a consistent service delivery and reassessment of client needs. And leave an open door. Don't give up. If Jim Bob relapses, okay, this is a learning opportunity. Let's figure out what we missed in your relapse prevention plan and how we can keep it from happening again. Relapse strategies. Educate families and clients about the symptoms, causes, and effects and interactions of co-occurring disorders. If depression triggers use, what are the signs of depression? Why would depression trigger use? If I relapse and I'm on antidepressants, what's that interaction going to look like? Is it going to make my depression worse? Yeah, probably so. Recovery. How is recovery going to interact with your mental health issue? Probably going to improve it. So let's look at what needs to happen, but we need to treat everything as one, because you can't just split Jim Bob into three and go, okay, we'll treat your substance abuse, we'll treat your mental health issues, and we'll treat all your other crap. Treat it all at once. Identify relapse triggers and interventions, develop a plan, and use behavioral contracts. If I feel like using, I will. I have my clients keep it 3 options on an index card in their wallet. If I feel like using, I will call my sponsor. His phone number is blah, blah, blah. Call a friend. Their phone number is blah, blah, blah. Call my counselor. In early recovery, that may be all you can get. They need to have it available when they are wanting to use. They're not thinking clearly. Be aware of family substance use. It's going to be real hard for Jim Bob to stay clean and sober if everybody in the family drinks in front of him. Discuss the meaning of their drinking in front of him or their insistence on keeping alcohol in the house on Jim Bob's recovery. It's almost like creating a self-fulfilling prophecy or being unwilling to compromise. Provide treatment information if necessary, and if the environment is not going to be clean, sober, and safe, provide options to the patient for where they might be able to find new housing, at least temporarily. Group treatment involves developing group cohesion. Use some rituals with caution. There's enough ritualistic abuse out there that I tend to not use a lot of rituals, but something such as starting out group with a serenity prayer builds cohesion. Have an emblem or a mascot. That's always fun. It gets people talking and choosing a mascot, and you say, well, why did you choose the donkey? Well, because he's stubborn. Well, okay, that's a good reason. Let's talk about why we want this to be our mascot for group. Explore group response to dropout or relapse. If Sally quits coming to group, don't just say, well, Sally's not coming anymore. All right, what we're covering today. The group has feelings about that. Frustrations, disappointment. It may increase anxiety in them because they thought Sally had it covered a whole lot better than they did and she relapsed. So what does that mean for them? Don't have a group of larger than 12. Some places will go up to 15, assuming that 3 probably won't show up on any given day. Make sure you write out group rules and expectations, including communication, attendance, behavior, etc. The big one for communication is using I statements and owning your feelings. You didn't make me feel such and such. I feel such and such. I am choosing to feel such and such. And make sure to remove ambivalent or pre-contemplative clients because they're just going to undermine the work that the rest of the group is doing. If you have clients who are withdrawn, discuss their lack of participation. Assess them for learning and cognitive difficulties. Maybe they're just not getting it. Maybe they're clinically depressed. Maybe something else is going on in their life. Pair them with buddies, and this is a good idea to do universally. When a new person comes into your group, if you've got an open group format, pair them with somebody who's been there for a while, who can tell them what the format is, what it's going to look like that day. Incorporate buddy activities, little things that they can discuss, reviewing their relapse prevention plans together. You can come up with some creative things that can be pretty fun, and it makes the time go a whole lot faster. Evaluate them for mental health issues. Provide alternative methods for participation. If you have a client, for example, who stutters, he or she may not want to speak up in group. So what alternative methods do you have? Maybe he or she could write something down on a piece of paper and hand it to you on the breaks if they have a question or want to say something. And ensure an environment of safety. So people who are anxious feel accepted and feel like they won't be criticized or laughed at. Safety in group. No tolerance for drugs or weapons. No tolerance for drug-related activity or romanticizing past drug-related experiences. No unauthorized persons on the site. Susie's boyfriend does not come to the door to pick her up to the group room door. He may come and sit in the lobby. They need to sign a code of conduct, recognizing that violence will result in termination. And where I've worked before, we've also had to have actually a dress code. So depending on where you work and how you feel about some of these things, more or less may need to be included in your rule sheet. Try to keep it one page or less. Anything much more than that, they're not going to remember all the rules, and they're going to use that as an excuse to break them. What to do with clients under the influence? Assess them for acute care or detox. Are they in a medically tenable situation? If so, make the referral. If they have somebody who can come pick them up and they just need to go home, that's fine too. With today's influx of people abusing opiates, that used to be very common for someone to take pain pills before they came and be dozing off in group and triggering all the other clients. So while sleeping off the opiates is probably not a medical crisis, they probably need to go home so they're not triggering the other clients. Review the rules with the client, instruct them to return when they're abstinent, arrange for safe transportation home. Make sure to invite the client to return to treatment. This is not a punitive thing. We're not going to hold it over their head and go, well, you screwed up last week, let's see what you can do this week. No. Call them. Let them know you're concerned. Let them know you want to help them figure out how to overcome this relapse. And discuss substance use during the next session. Make sure you get releases anytime you need to share information. If you're going to transfer a phone call to the client or take a message for the client, you cannot acknowledge, confirm, or deny a person is in your program. If you're going to be handing a phone to the client, you can't just say, oh, you want to talk to so-and-so? She's right here. That breaches confidentiality. If you take a message for Sally, the best that you can do is say, if Sally's in the program and if she's here today, then I will give her the message. If she's not a member of this treatment center, then I'm not going to be able to deliver the message. Ideally, don't take messages for your clients. If the HIV status is withheld from their partner, ensure the client is knowledgeable of how HIV and AIDS is transmitted. Discuss with them their feelings of fear, embarrassment, or guilt about revealing their HIV status. Educate the client about HIV and, if you can, the family in family sessions, not necessarily just their family, but in a family education session. Refer the client for HIV/AIDS counseling and provide referrals for support groups. In most states, it is illegal for you to reveal a client's HIV status. Make sure you know your state laws. Treatment-life balance. Remember we talked about from the bottle to the meetings? Well, recovery is your first priority. If you're not clean and sober, all the rest of your life is going to go to wherever. This is not the time to try to make up for the past, missing all the ball games or not going to the recitals or just generally being a not nice person. This leads you to take on too much. You're starting over, you're starting fresh, it's a clean slate. Be the person you want to be now. Ensure a balanced lifestyle between treatment, family, work, honeydews, and private time. There are high-risk situations. Be aware of them ahead of time. Distance yourself from coworkers or family using substances. That doesn't mean you have to cut them off, but it may mean you don't go over and sit in their living room on Sunday afternoon while they're smoking a joint and drinking a beer and watching football. Role-play refusal skills. If your work environment is untenable, if people are smoking marijuana on the job site, or the people around you just serve as triggers for whatever reason, you may need to look at getting a transfer to another work environment. And I mean this for the client, not for us, the counselors. Boundary issues with clients. Gifts. Every once in a while they'll bring you a gift. Depending on your agency's policy and where you stand on your interpretation of the ethical guidelines, you need to evaluate the cost of the gift. If they bring you a card on Christmas, do you have to give it back? Cultural significance. If you take a Christmas card and say, no, I can't accept this, what is that communicating to the client, and is this culturally significant for them? Look at the timing and the motivations. Are they trying to butter you up before they do something, or because they've done something? It's best to just state a policy at the outset that you are not allowed to accept or give gifts. Don't sponsor your clients. It's a dual relationship. There are plenty of sponsors out there. I cannot fathom a situation where this would be an unavoidable dual relationship. Do not sponsor your clients. Socialization outside of treatment's a little more tricky. You may go to the same gym. You may shop at the same grocery store. You may go to the same meetings. In some small towns, there's only one NA meeting or only one AA meeting. So if it's an unavoidable situation, make sure you address with the client at the outset how you're going to handle that. If you see them in the grocery store, are you going to acknowledge them? Are you going to wait for them to acknowledge you? If you see them at a meeting, how are you going to handle that? "12 steps, the strengths. They're free. These meetings are all free. They're widely available, supportive, and specialized. This is addiction we're talking about. It's not addiction and depression and schizophrenia and relationship problems. We're dealing with the addiction. It emphasizes an array of recovery tasks, including cognitive, changing the stinking thinking, spiritual, aligning with a higher power or at least good orderly direction, and taking care of your health. And it's effective with clients from diverse backgrounds. The challenges with 12 steps include monitoring compliance with step tasks. They're working on these tasks with their sponsor. Now, if you can get the client to sign a release so you can talk to their sponsor, that's just ducky. Or maybe you can have a group session once a month or once a quarter. That's great too. Maybe you can have the client bring you evidence of their step work. There's lots of ways around it, but it's not something that's super easy. Some clients have difficulty accepting a higher power. Good orderly direction. If you're going to Kansas from Minneapolis, you're going to get out a map and you're going to chart your route. Your end point is recovery. That's where you're going. You need to chart out your route and make sure you don't take any detours. That's what we call good orderly direction. It's your roadmap for recovery. Think before you act. If what you're doing does not get you to Kansas, then you've got a problem. Difficulty supporting 12-step or dual recovery meetings in small communities. Some very small rural communities may not have 12-step meetings or dual recovery meetings. So encouraging clients to go online, go to In the Rooms, which is an online 12-step meeting. That's one place to start. It's better than nothing. The cognitive behavioral approach. Emotional and behavioral reactions are learned. New reactions can be taught. Clients learn to recognize and respond to substance abuse and mental health triggers. And this is kind of along the lines of smart recovery. The strengths of CBT is that it engages clients in therapy and learning. It's very manualized. There's actually a CBT recovery protocol. It's suitable for diverse clients, and it provides very structured relapse prevention strategies. It doesn't, however, help with establishing a wide social support network. With CBT, you need to adjust for clients with poor cognitive skills. It does require extensive counselor training. The client has to be motivated to look at his own stuff. It does have homework assignments, and it was initially developed for individual counseling, so generalizing it to group work is going to be more of a challenge. It's not insurmountable. Just looking at the different pros and cons. Motivational interviewing and motivational enhancement therapy acknowledge that substances have rewarding properties. We just need to make recovery more rewarding than use. Easier said than done. It's paired with strengths-based problem-solving strategies. We don't reinvent the wheel. We take the strengths the client has and the goals the client has, and we try to work those all together into recovery. They have strengths. And counselors act as coaches and cheerleaders. It's up to us to say, you're doing what you're doing, and you're staying clean, so it sounds like you're doing what you need to do. The strengths is that it's client-centered and relevant to the client's interest. It focuses on realistic goals and encourages self-efficacy and self-sufficiency. It also emphasizes positive support. I'm going to cheer you on, and I'm going to teach you how to evaluate your accomplishments and your successes and cheer yourself on. It does rely on the client's capabilities and self-awareness. If the client can't evaluate irrational cognitions and thought distortions, they're going to have a difficult time with this particular approach. It's not common, or it's incompatible with common problem-oriented assessment instruments. This is strength-based, not problem-oriented. We're not trying to identify all the deficits. We're trying to identify what Jim Bob already has and work from there. It does require training and supervision. It can be difficult to implement in a therapeutic community. Not impossible. It too was developed as an individual approach and does not specify session content. So it's not something you can give a technician and say, here, go do a group on motivational interviewing. It requires too much training, and it doesn't tell you. It's not a monkey see, monkey do curriculum. Therapeutic communities. The entire treatment community is the therapeutic agent. Everybody is constantly picking each other up and calling each other out. It views addiction as a disorder of the whole person, and recovery as a developmental process entailing mutual help and social learning. That means you've got to relearn how to act and react to life. It too is a phased treatment approach. Very, very structured, and at least as I have experienced it, very confrontational. It's effective for people with long histories of addiction and antisocial behavior. It helps teach clients how to achieve goals and can reduce recidivism. TCs are usually like 6 months to a year to 2 years. So new behavior patterns are sort of integrated into the person by the time they leave. It may be too confrontational, especially for someone with co-occurring mental health issues. Requires a lot of staff training. It's difficult for clients with co-occurring disorders, especially if they're in the middle of a mental health episode. And it requires an effective mix of clinicians and recovering staff. The matrix model integrates several techniques, including CBT, 12-step, and motivational enhancement therapy. It emphasizes group work because the group can support and call out over individual sessions. The primary therapist coordinates the client's treatment, and the client-family relationship is critical. Again, family is whoever that person calls their family. It doesn't have to be a blood relative. Core components of the matrix model include early recovery groups and teaching cognitive tools for managing cravings and structuring time. When you start having cravings, when you start thinking about using, what do you need to do? How do you need to change your thinking? How can you stop romanticizing the past? Family education sessions revolve around the causes of addiction and the biopsychosocial effects of addiction. And relapse prevention groups address cognitive and behavioral change. How do you need to change your thinking and your actions to embody this clean, sober person that you want to be? And social support groups provide an opportunity for networking, social support, and for those with recovery to model relapse prevention. And it also includes urine testing. The strengths is that it integrates CBT, family involvement, education, 12-step support, and urine testing. It integrates a lot of those things that we've already talked about. It's manualized, so it's easier to use with less trained staff. And it can be effective with people dependent on stimulants. Initially, this was designed for people who were addicted to methamphetamine. Challenges include necessary modifications of material for clients with impaired cognitive functioning. If you've got somebody who has dementia or who is cognitively impaired in some other way, you're going to have to modify the material. It does require staff training and supervision. We're generally in class, in school, not taught how to integrate all of these things. We may not even be taught any of these things. So it's important to make sure that staff is trained and everybody's on the same page. It may not appeal to all clients, especially those not wanting their family or others involved. They may want to just be starting fresh. And it may not allow for treatment of non-drug related problems, such as mental health issues. Community reinforcement and contingency management is based on operant conditioning and uses frequent incentives to reward clients, such as vouchers. This model reduces drug use significantly and combines readily with other interventions. It's used a lot in drug court programs. It can be implemented with low-cost incentives, including donations. There's extensive scientific support. It's basically a token economy. Challenges include what happens to the client's behavior when the incentives are gone. It is labor intensive because you have to keep the point sheet. Staff training and frequent client attendance are mandatory. And there need to be sufficiently large rewards for continuing appeal. You can't just regularly give out a voucher for a movie pass and expect that to maintain its same rewarding qualities. Community reinforcement also does not emphasize long-term supports. Specific populations. Criminal justice. They have special issues such as finding an employment, somebody who will employ them with a felony conviction. How to handle finances, where they can get low-cost housing, especially if they've got a felony conviction. Transportation, if they don't have a car or don't have a driver's license. Education, learning disabilities, co-occurring disorders, and medical issues such as HIV, TB, or hepatitis. Counselors work with justice system participants, and we need to define discharge criteria, how we're going to use drug test results, and the consequences for noncompliance and or relapse. So you need to get your probation officers and your judges and your drug court people together, and we need to develop a plan for what's going to happen if Jim Bob tests positive. What's going to happen if Jim Bob gets kicked out? What does Jim Bob need to do in order to successfully complete? If you've got the support of the courts, you're already 20 yards ahead, because there are so many punishments and rewards inherent in the criminal justice system that you can work to align with the client and encourage him or her to make the next right choice to avoid punishment. When you're working with the courts, you have to identify each partner's responsibilities, consequences for a professional or for agency's noncompliance, types of content that need to be reported to the team, and a schedule of reporting. Are you going to meet weekly, monthly, quarterly? And what to do if there's a critical incident. Women may have special issues, including a history of violence, mental health issues, parenting skills, parenting knowledge, or custody issues, child care issues. They may have special needs children that they're taking care of. They may be on welfare. They may be pregnant. Relationships, and just simple fact that a lot of treatment programs can be somewhat insensitive to the needs of women. Adolescents may require habilitation rather than rehabilitation. That means they've never had the skills or tools needed to deal with life on life's terms. It's sort of a reparenting because their parents missed it on the first try. That's not always true. It's important to assess what strengths and what skills the adolescent already has. They have really short attention spans and limited future perspectives. They may be thinking about homecoming or their date on Saturday. They're not thinking about where they're going to go to college and what they're going to do for a job in 15 years. Sometimes they have limited ability to think abstractly, depending on what age group we're talking about with adolescents. That's a pretty wide age range. It may require parental consent for treatment. And more than half of adolescents with addictions also have mental health issues going on. So we know that we can expect, just like we can with the adults, the adolescents to have co-occurring disorders. Co-occurring disorders combined with hormones, well, you do the math. Cultural competence. Use a holistic worldview. Identify issues of spirituality that may be important to your clients. Remember that not every culture values independence. So don't have your program focus exclusively on independence. Respect the cultural values of your clients. Remember there are differences in verbal and nonverbal communication. In some cultures, it is impolite to look somebody directly in the eye when you're talking to them. Respect the fact that there are multiple learning styles and everybody deserves to be treated with respect and dignity. Specific cultures, just to name a few, and this is not inclusive, Hispanics and Latinos, African Americans, Native Americans, Asian Americans and Pacific Islanders, persons with HIV and AIDS, lesbian, gay, bisexual, and transgender clients. We've already talked about women, criminal justice clients, adolescents. They all have their own cultural beliefs and values and behaviors, and some of them overlap, some of them don't, but we need to be sensitive to what is going to be most appropriate for that person. Persons with physical and cognitive disabilities. Not every person who is deaf wants to become hearing. There is an entire culture around being deaf, and some people are very invested in their culture. Don't assume. Rural populations, homeless people, older adults. The list can go on and on. If you individualize treatment and you ask the client what their needs and preferences are, you'll be fine. Here are some resources that you can look at that will expand upon what we've talked about. In summary, IOP or IoT has many challenges but provides a fair amount of flexibility. It can be used in conjunction with contracts and rewards and phased up or phased down depending on how the client is doing. You need to use community resources to relieve some of the burden on your program. You are the clinician. If you can integrate with case managers and financial counselors and other people, it will greatly relieve the burden off of you and also free you up to do what you do best with more consumers.